So, good evening and welcome in this fifth episodes of this IAP NRC General Club. And I welcome our chairperson, sir, Dr. Rawat, sir, our coordinator, Dr. Indu Khosla, ma'am, Dr. Joseph, sir, our national expert, then our EB member like Dr. Santanu, sir, Dr. Kasi Bhandaru, and uh, and other EB members. And I also welcome our presenter, Dr. Satya Srivastava. He is DM Fellow Pediatric Pulmonology from the AIMS Jodhpur. And I also welcome Dr. Jagdish sir, our past secretary, as well as he is the mentor of this session. He is working as a professor and in charge Pediatric Pulmonology Division in AIMS Jodhpur. And I think, sir, Dr. Joseph, sir, is not here at present. Yes, Dr.
He is
Joseph, sir,
there.
is here. Yes, sir. I also welcome Dr. Joseph, sir, our national expert. And I also welcome my colleague, Dr. Praveen Kumar, from additional professor from AIMS Jodhpur. So with these words, I think our session expert is not here, Dr. Susan Mane. Okay, let us see.
We'll start it.
Okay, sir. So now I hand over the session to our national coordinator, Dr. Indu Khosla, ma'am, to take carry forward. Please, ma'am.
Yeah, I think without much ado, we should start. And I invite Dr. Satya Srivastava to start his presentation, and we will discuss it as we go forward. We are again focusing on tuberculosis this time, but let's go through the presentation, and I thank the NRC to give the opportunity for the youngsters who are studying to learn about how a journal article has to be reviewed. And I think ever since this journal club has started, I have started looking at every article with a suspicious eye. And then at the end of it, I say, okay, should I really take value out of it or not? And I'm sure all of us are benefiting a lot with these youngsters who are doing a brilliant job of presenting. Over to you, Dr. Srivastava.
Yes, ma'am. Thank you. Is my audio and video clear, ma'am? Is my screen visible to all? Thank you.
Yes, yes. And
good evening, everyone. Today we'll be discussing an article as part of the IAP NRC Journal Review Club. And this article is titled Characteristics of Children and Adolescents with Multi-Drug Resistant and Rifampicin Resistant Tuberculosis and their association with treatment outcomes. This is a systematic review and
I think, Dr. Satya, you are disconnected.
I'm just call him and get back.
Please.
If there are network issues, he can switch off his video and speak.
He'll call him and see.
Satya, you are disconnected, I think. You can disconnect your video and then he's joining in 2 minutes.
Okay. Are there rains in Jodhpur?
No, sir, but there was power cut. So that's why means Wi-Fi disconnected.
Sir, can I have screen sharing?
Oh, joined.
Yes, you can do it.
Sir,
You allowed it.
Yes, sir. Is my screen visible, sir?
Please go ahead.
Yes, sir. So sorry for the technical delay. So we'll be discussing article as per the IAP Journal Club review. And this article was published in the Lancet Child and Adolescent Health in February 2025, and volume number 9, issue number 2. Impact factor of this journal is 19.8. So just to brief what we'll be going through, we'll have a brief background on what is DRTB and what is the new changes in the guidelines, and what is the evidence before this study, and what is the research gap. And we'll be seeing the objectives, methodology, results, strengths, limitations, conclusion, also the future scopes that can be done after this study. So around 32,000 children less than 15 years of age develop MDR, rifampicin resistance TB globally each year. And as per NTP, the prevalence of MDR TB is around 2.8% among new cases and 14% among previously treated patients. As we know, pediatric TB is a possibly disease, especially more so in children less than 5 years old, and hence it is less severe compared to adults. However, adolescents are more likely to develop adult-like pulmonary tuberculosis, especially in the 15 to 19 years age group, who may have worse treatment outcomes as compared to the younger children. So what are the different definitions of resistance in tuberculosis? Monoresistance TB is only one first-line anti-tuberculous drug only, and isoniazid resistance TB comes under that, which is resistance detected only to isoniazid acid. As for polydrug resistance TB, there is more than one first-line anti-TB drug resistance detected, other than isoniazid and rifampicin. Rifampicin resistance TB, as the name suggests, is rifampicin resistance is detected with or without other anti-TB drugs resistance. MDR TB is resistance to both H and R, with or without resistance to other first-line anti-TB drugs. Pre-extensively drug resistance TB or pre-XDR TB there is resistance to H and R along with any one fluoroquinolone. And XDR TB is the presence of resistance to INH, rifampicin, fluoroquinolone, and one additional group A drug, either bedaquiline or linezolid. So what are these different groups of drug as given by the WHO? So these are classified into group A, group B, and group C as per safety, efficacy, and order of preference to be included in the drug regimen for treatment. So group A drugs predominantly include fluoroquinolones, bedaquiline, and linezolid. Group B drugs clofazimine, triclocerin, and terazidone, and other drugs fall under group C category. So final treatment outcomes for MDR TB, rifampicin resistance TB is either you can have favorable outcomes like treatment cured or treatment completed, or you can have unfavorable outcomes like treatment failed, died. So under cured, a patient is cured when he is diagnosed bacteriologically confirmed TB with pulmonary TB at the beginning of treatment, who completed treatment as recommended by national policy with evidence of bacteriological response and no evidence of failure. And a patient who has completed treatment is who has not met the definition of for cure or treatment failure, but he has completed his duration of treatment. Other negative outcomes include treatment failed and died. And treatment failed is a patient who treatment change needed to be terminated or permanently changed to a new regimen or treatment strategy. And a patient who died before starting treatment or during the course of treatment comes under died. So treatment success is sum of all patients cured and treatment completed. So let us see briefly what are the new changes in guidelines. First of all, when to suspect drug resistance TB. When there is history of close contact with drug resistance TB case, or a child who does not complete a full course of drug sensitive TB treatment, or if there is other factors like inadequately or poorly administrative treatment, especially in children with HIV positive patients with active TB, they are more prone to have drug resistance TB, and also suspect in areas where DRTB is common. So when do we say a child is confirmed drug resistance TB? Is when the investigations reveal drug resistance, especially from an NTP quality assured culture and DST laboratory, and by an NTP endorsed testing method like nucleic acid amplification testing, line probe assay, or culture. So this is the integrated diagnostic and treatment algorithm for drug susceptible and resistant tuberculosis. Once a child is diagnosed with resistance rifampicin is divided into two groups, either less than 14 years or more than 14 years. So a child who is more than 14 years should be evaluated for eligibility for the BPAM regimen, which includes bedaquiline, predominant linezolid, and moxifloxacin, and the treatment duration is of 6 months. It's an all-oral regimen. If he is not suitable for BPAM, or if he is less than 14 years, then he has to. The second preferred regimen is 9 to 11 month shorter oral regimen, which and if there is in which there should be no resistance to fluoroquinolones. But if there is resistance to fluoroquinolones, or if he's not eligible for the shorter regimen, he has to go for the longer regimen, which is around 18 to 20 months. So a similar meta-analysis and individual patient data systematic review was conducted by the same primary author in 2014, and it was published in 2018. And according to the authors, they revealed the median age of the participants in the study was 7 years, and children with confirmed MDR-TB were tended to be older, HIV infected, or malnourished, or had severe TB on chest radiography as compared to clinically diagnosed TB. And they also found that the factors associated with treatment success were children who were taking both ATT and ART in HIV co-infected patients as compared to taking ATT alone. And the use of second-line injectables and high-dose INH was also associated with positive outcomes. Following this meta-analysis, there have been a number of changes in our DRTB regimens and guidelines, where the most importantly is the addition of the current WHO recommended anti-TB drugs, which are all injectable sparing. The regimens are predominantly oral regimens where there is inclusion of fluoroquinolones, linezolid, clofazimine, bedaquiline, delaminate. But the data on uptake of these novel treatments in children and the effect of these treatment outcomes have not been studied. Also, these regimens are reduced treatment duration as compared to previously. In the previous study, as we saw, the median age was only 7 years. So more number of children to be included, in addition of older adolescents also into the pediatric TB cohort could help. So coming to the study proper, which we'll be discussing now. The objectives of the study was to describe the demographic and clinical characteristics of children with MDR or rifampicin resistance TB, and to describe the treatment regimens and also describe the treatment outcomes, and to characterize these clinical and treatment factors associated with treatment outcomes. So the primary effectiveness outcome which they studied was treatment success versus treatment failure. And the study was conducted as per PRISMA guidelines. They have included multiple studies, both published and unpublished data. They have also taken data from international clinical trials registry and also national TB programs, and also contacted field experts who were in different countries who were experts in tuberculosis. For the inclusion criteria, they have included children 0 to 19 years with microbiologically confirmed or clinically diagnosed MDR rifampicin resistance tuberculosis. And the studies were included which had more than 5 participants, and the treatment and the outcomes had to be defined as per the cohort. Ethics approval also was taken. Exclusion criteria, all other resistance like monoresistance TB and when there is treatment duration was implausible, these studies were excluded. And also studies which had missing outcome data on TB treatment outcome, and also study designs which were inappropriate were also excluded. The risk of bias for included studies was independently assessed by 2 authors using the Joanna Briggs critical appraisal tools, and most studies were just to have moderate to low risk of bias. Ethical committee approval was taken and the study was also registered. So after including studies, the authors contacted individual study authors and they asked for individual participant data. And the data which are extracted from these studies were baseline patient characteristics and also TB characteristics, like was this a clinical or a confirmed diagnosis, AFP smear microscopy result, whether it was predominantly pulmonary or extrapulmonary TB, and history of failed first-line treatment. They also took data on treatment details like what was the regimen duration, what are the medications used and dosage given, and also whether the treatment had the different treatment outcomes like success and failure and time to treatment outcome. So ultimately 1,417 studies were identified, and 51 studies for which IP individual participant data were sought from published studies, and also they had taken from other studies from unpublished cohorts. And finally, after a stringent exclusion policy, they arrived at 42 studies were included. And out of these 42 studies, they have formed 2 cohorts. One is an overall cohort and one is a primary analysis cohort. So overall cohort was comprising 23,369 participants, it included patients who were also lost to follow-up. The authors believed that including these patients would be more of a realistic real-life scenario and representative of a real-life scenario, and also provide complete picture of programmatic outcomes. And for the primary analysis cohort, they excluded the lost to follow-up patients because they wanted to focus on definitive treatment outcomes. Statistical analysis was done. They described the baseline clinical and demographic characteristics and outcomes for both overall and primary analysis cohort. Multiple mixed effects logistic regression models were used to identify factors associated with treatment success and adjusting for clinical and treatment characteristics. Sensitivity analysis were performed to assess the impact of the loss to follow-up patients, and results of this meta-analysis considered statistically significant at p-value less than 0.05. Now, coming to the results, this table depicts the demographic and clinical characteristics of children and adolescents in the overall cohort. And as we can see, highlighted in the yellow, the median age of participants included in the study was 17 years. And if you stratify based on the age, like less than 5 to 10, 10 to 15, and 15 to 19, the predominant participants were in the adolescent age group more than 10 years, and the representation of children less than 10 years were only around 12 to 13%. The HIV positive patients are around 14%, and if you see the TB status, most of the patients belong to microbiologically confirmed disease, and the representation of clinically diagnosed patients only 10%. Patients predominantly belong to a pulmonary tuberculosis rather than extrapulmonary tuberculosis, and treatment success was seen. The median duration of treatment success was 19 months, and the patients who died treatment and failed were around only 5 months of treatment duration was done. So in summary, the overall cohort results age less than 15 years only. The treatment success was seen in 80% of patients, deaths were 9.2%, treatment failure in around 2% patients, and loss to follow-up was 8.6 patients. Now, this table depicts the demographic and clinical characteristics of participants in the primary analysis cohort. And similarly, as we saw in the previous table, the representation of 1 to 10 years children was low as compared to adolescents. And predominantly, children were belonging to the low income or lower middle income countries, around 70%. And the pattern of drug resistance was seen. Fluoroquinolone resistance was only 17%, second-line injectables around 11%, and fluoroquinolone and second-line injectable like XDR TB was seen in 22% of children. Predominantly, children were microbiologically confirmed, and only 10% were clinically diagnosed TB, and site of disease were more likely to be pulmonary. So, children who had acid-fast bacilli smear positive, like multibacillary disease, were associated with death and treatment failure, around 70 to 83%. And also, the authors noticed that as the age tends to increase, there is a higher chance of microbiological confirmation. As we see here, age less than 5 years, only 75%, 5 to 9 is 85%, age 10 to 20 is almost close to 90%. So this is a forest plot depicting all the 42 studies and showing the proportion of successful outcomes as compared to all the outcomes. And as we can see here, the heterogeneity is around 60.7%. Hence, taking a random effects model, the pooled estimate of this study showed that treatment success was seen around 85% of children. So coming to individual clinical factors and adjusted odds ratio, as we can see here, all the p-values are significant less than 0.05, and hence factors with negative association in treatment success were the older age, male sex, people with co-infected HIV, previous history of previous TB treatment, having current pulmonary tuberculosis, and also AFB smear positive. All these factors are associated with negative treatment outcome. Interestingly, they also noted that those microbiologically confirmed tuberculosis as compared to clinically diagnosed tuberculosis had a better outcome as compared to a clinically diagnosed tuberculosis. Similarly, with extrapulmonary TB as compared to pulmonary TB only, the odds of treatment success was higher. Here, the clinical factors were again compared, now stratified for age. So what they have seen that in the 0 to 4 years age group, children who were from the upper middle or high income countries tended to have a treatment success associated with higher odds of having treatment success. And similarly, to summarize this table, factors with negative association stratified by age, children who are more than 10 years would have negative treatment association, male sex more than 10 years, throughout all age groups if they have HIV positive, and microbiologically confirmed TB between the ages of 5 to 9 years, previous history of TB treatment more than 5 years of age. Pulmonary tuberculosis between 5 to 9 years and between 15 to 19 years was associated with higher adjusted odds of having treatment failure. And multi-personality disease across all groups also had negative association with treatment success. So in this table, they have compared the number of group A, group B, and group C drugs used as compared to none of the drugs being used in this particular group with treatment success and failure. And as you can see here, the p-value is significant for both 2 or 3 group A drugs used as compared to no drugs used. So use of 2 or 3 WHO classified group A drugs was associated with higher adjusted odds ratio of treatment success. And they also found that the use of 2 group B drugs as compared to not using any group B drugs was associated with reduced odds of treatment success. Here they have seen the number of drugs used and stratified it age-wise. And as we can see, there is a strong association, p-value is less than 0.05, and strong association of use of 2 or 1 group A, 2 or 3 group A drugs in the age of more than 10 years. And similarly, as we already saw, the use of 2 group B drugs was associated with negative association with treatment success. So coming to summary of the use of individual drugs in children, they have stratified it by country, by age, and HIV status. And since predominantly the participant proportion was from India and South Africa, almost 90%. So they have compared the 2 countries only. And as we can see here, comparing the 2 countries, there was higher use of ethambutol and injectable aminoglycosides, cycloserine in the Indian cohort as compared to South African cohort, where teracidone had a very high proportion of use. And coming to the age-wise stratification, children less than 5 years of age had higher proportion of use of high-dose isoniazid, amikacin, ciprofloxacin, and prothionamide as compared to other age groups. And there was no significant difference stratifying the usage of drugs between both HIV or HIV negative. So the key findings of the study is, 1, the underrepresentation of young children and those with clinically diagnosed TB. So pediatric TB is possibly, and sometimes there's an absence of guidelines on how to use these new drugs, and also there can be limited access to these new drugs. So that could be the reason why there's underrepresentation of young children. However, this underrepresentation is a crucial omission because as per NTP, it's been found that most deaths in TB are children less than 5 years of age who do not receive ATT. And coming to the proportion of treatment success in children under 15 years was 80% as per this study, and compared to previous meta-analysis, it was 78%. So here it implies that an oral-based regimen was having equivocal efficacy as compared to an injectable-based regimen. And in the overall cohort, including loss to follow-up patients, 72% of children and adolescents were successfully treated. But the WHO end tuberculosis strategy target is success rate in around 90% or more individuals. So there is a scope for improvement in DRTB management and treatment. Other key findings were group A drugs was associated with better treatment outcomes, especially in adolescents, and inclusion of 2 group B drugs was associated with reduced adjusted odds of treatment success. So what the authors have hypothesized is that this could be because of more severe disease or organisms which might be XDR isolates, thus requiring more group B drugs, and maybe could be the reason why there's a reduced odds of treatment success. So the strengths of this study is the largest data set of children and adolescents with MDR and RR tuberculosis globally to date. And it also include data on the oral drugs like linezolid, clofazimine, later generation fluoroquinolones, and novel drugs like bedaquiline, delamanid in children and adolescents. This study has also evaluated the outcomes of shorter duration of treatment regimens, and they also included adolescents who were previously being included in the adult cohort. However, most data was taken from South Africa and India, and generalizing the results of this study to other geographical regions should be done with caution. And they have also included certain studies which had sample size less than 5 participants because it was a continuation of the previous meta-analysis, and so that could lead to small sample bias. There is very less data from certain high burden countries in the Western Pacific region. So geographical distribution bias is there. And loss to follow-up patients might be associated with treatment regimens that are long, poorly tolerated, or less effective. And sometimes it can also include an unreported death. So possibility of bias due to complex interplay of such factors have to be taken in mind. The number of children who received delamanid were very less. So the optimal role of delamanid in MDR, rifampicin resistant TB in children, is yet to be defined. And this study has also not given any data on adverse effects of drugs and the safety of different regimens. So to conclude, although vast progress has been made to improve MDR and RR-TB care in children and adolescents, more efforts are required to better identify individuals with TB across the age spectrum, especially young children, and to ensure equitable access to the best, shortest, and most safe medications and treatment regimens, and to achieve target treatment outcomes as per national and global guidelines. So future scope, proactive case finding and surveillance with stronger focus on young children with MDR, rifampicin resistant TB, and data on disease severity correlation with treatment outcomes, effect of fluoroquinolone resistance and nutritional status on treatment outcome can be studied, and also data on regimen safety can be reported. So coming to the reporting assessment Prisma checklist, this study was done using a robust methodology, and the authors have complied by the checklist and they have filled all the checklists. Thank you.
Dr. Satya, we are having time. You can just, for the sake of reader, means sake of the audience, you can just go through this checklist.
Okay. So they have identified the report as a systematic review, and even the abstract guidelines were reported. And methodology, eligibility criteria, information sources, search strategy, what was the selection process they have used, and how did they collect the data, and also data items, each of them were reported in the study. Study risk of bias assessment was done using Briggs-Joanna scale, and effect measures were also documented for each outcome. They have documented, and they have also described the process used to decide which studies are eligible for which synthesis, which outcome data, and reporting data biasment was done. Certainty assessment was also reported. Results study selection was done using a stringent methodology, and study characteristics, they have cited each study and presented its characteristics. Risk of bias in each study was reported and assessed, and results of individual studies for all outcomes questions for each study were also tabulated or given visually, and result of synthesis was also described. Reporting biases were also described, and certainty of evidence was provided as by the authors. Coming to a discussion, they gave a general interpretation of all the results, and they did provide limitations in the evidence and also limitation of the review process used, and discuss the implications of the results for practice, policy, and future research. And it was a registered study. It followed a protocol, and they did so. However, they did not explain any amendments or to information provided at registration or in the protocol. Apart from that, support, funding, everything was described and reported in the study. There was no competing interest of review authors, and data has been available and it is published also. Thank you.
Thank you, Dr. Satya. That was quite a detailed and a quick analysis of the talk. I think one of the biggest drawbacks that I thought in this study was the way the number of percentage of patients who dropped out. You can maybe stop screen share. Yeah.
Satya, you can stop sharing.
Then the percentage of patients who dropped out, and then they used an analytical method called as mice, where they extrapolated to say that most of them would have responded. And I somehow failed to understand what was that they used to say that they responded when there was such a large dropout rate. Any comments on that? You're mute.
So sensitivity analysis was done where they have included loss to follow-up patients, and they have included them in both unfavorable outcomes and also favorable outcome. And what they have found out is that it does not change the final outcomes, even clinical, demographic, and also treatment factors associated with treatment success and failure.
Dr. Joseph, would you like to comment on this?
Yes, on this question or generally?
Yeah, on this and even generally, of course, you're.
No, this question is all right because mice is regarded as one of the methods when there is data missing to collect data from the available data and then impute it. It's not the perfect method, but in the absence of data, this is also done sometimes. Now, the other comments regarding this, Dr. Satya has, on the plus side, extensively summarized in the introduction what this MDR, TB, and all the terms are. He has also faithfully reported whatever is published in the paper. On the downside, there has been no critical appraisal or analysis of what these people have done. So let's look at a few things in all. Now, this paper identified 51 new studies after 2014. The same authors had published something in 2014. And interestingly, out of the 51 included studies, 51 have got excluded. If you look at the table, figure 1, the Prisma chart. Now, what they're not telling us is, are all those 51 which turned up, are all of them excluded, or are these something else? In fact, the only studies which finally got included are the 57, which didn't come up in their literature search at all. It's mostly unpublished data, previous systematic reviews data, and also something from their own databases and registries, which means most people in the will not be able to get this data from the public domain. So that is one point. Second thing is that the proportion of people who had MDR clinically diagnosed is about 10%. Whereas in most developed countries, that proportion is likely to be much higher. So there is going to be a skew because of the microbiologically positive cases being up to 90%. We all know that that's not likely to play out in real world. Then there are baseline differences between the groups with treatment success and the groups with death, and also the drop to follow out or loss to follow up kind of a thing. That is given in table 1. Actually, the juice of this whole paper is lying in the table 1. If you don't read table 1 carefully, you go away with the mistaken impression that all they have reported is so true, and it is if you use more than group 1A drug and this and that, everything will work. But the catch is that amongst those people who had treatment failure, there is a total disconnect or difference in proportion of previously treated cases, clinically diagnosed cases, AFB smear positive cases, drug resistance to second-line drugs. In fact, many of these so-called MDRs could be pre-XDRs also, and even the treatment duration itself. And interestingly, those are the very criteria being used to label a child or a group of children as treatment failure. So there is a little bit of a problem with interpreting the data the way it has been reported and the way Dr. Satya has done that. Interestingly also, completion of treatment itself has been taken as a definition of treatment success. So if a child completes treatment, he is deemed to have been successful, whether his outcome is clinically improved or not improved. So what about non-completion of treatment? Because that is one of the reasons why treatments would fail. That has been missed. Now, Prisma is actually not a critical appraisal tool for systematic reviews. It is just a tool for reporting the systematic review against certain set parameters. It's almost like in an RCT, the consort statement has nothing to do with the way the RCT was done. It's only a tool to report the RCT. So Prisma is not an ideal checklist, and in the chat box, Dr. Rashmi has actually mentioned one of the checklists which can be used. It's called the AMSTAR critical appraisal tool for systematic reviews in general. One last point which is important is the authors here claimed that all these 42 studies, they had done quality appraisal using a set of tools published by Joanna Briggs Institute, but they have not shown these data of what was the quality of these studies which they have included in the review. So in summary, like in most journal clubs, reading the results is meaningful only if we are confident about the methods used to arrive at those results. So here there are some issues with the methodology. So I don't think we can make much about the results until we have confirmed what is going on with the methods. Thank you very much. Rest I will take up in the chat box and other lines.
Even I was just wondering when I read this article about the criteria used for diagnosis. There was not much clarity on that criteria as well. Could you find it in one of the appendices? I could not really find it in the article per se.
No, ma'am, they have only said that macrobiologically diagnosed or clinically diagnosed only.
Yeah, but they did not really, and there are so many centers. So, what is clinically diagnosed? What are the criteria used? I could not find clarity in that. So, that also was something which caught my eye. Dr. Joseph, would you like to comment on that?
I have no idea because I have not seen the supplementary files with this paper.
Yeah. Dr. Mane, would you like to make a comment?
So the same thing, that is what we saw. The studies which are selected are very heterogeneous. I mean, they are not at the same plane. So comparing those studies becomes a little difficult. Like a very good point has been put in the chat box, which I was about to say by Dr. Pooja, that the regimens used are different. Some are using 4 drugs, some are using 5 drugs. The durations are different. Now in India, we just have a longer and shorter regimen, but WHO has gone ahead with 6-month regimens, 9-month regimens. So all this is a combination. So when we have such heterogeneity, it becomes very difficult to compare all the studies and give one drastic conclusion. And again, when you see the resistance pattern which is shown, I don't know how have they come to the conclusion that fluoroquinolone resistance is 17% and injectable is 12 and combined is 22. If you see India itself, fluoroquinolone resistance is 42%. So again, it becomes very difficult. I think, as Joseph sir said, the methodology is an issue due to which we are getting all these. I mean, this is like a picture perfect finding which you are getting from the study, which is not true actually when we see in clinical practice also.
True. Anyone else would like to make a comment?
Dr. Satya, quality of conjugal studies, like they were all RCTs or they were observational studies, because if they are RCTs, the quality of the review becomes much better. But if they are observational studies, the quality goes down. So what were the type of studies? They were RCTs or they were observational studies?
Yes, actually, they have taken all types of studies, sir, including case series, RCTs, and all sort of published data was taken. Even unpublished data also was taken.
Okay. So the study included a very heterogeneous, because it is, and then again it is very difficult to have a conclusion, because you cannot just compare observational studies, case studies with RCTs or unpublished data. So I think the population is the taken was very heterogeneous.
There was a question by Dr. Ajay Kumar. I think Dr. Joseph has already answered that why not use CASP checklist? But he says it's
Yes,
not one of
ma'am.
the best tools. So,
Yes, ma'am.
yeah. Any other questions or anybody else would like to make a comment? I think everybody wants to wind up early today. All right. So if there are no more comments and no more questions,
Dr. Joseph wants to say something.
yes, please.
Yeah, actually, the beauty of this paper is in a single sentence which has got missed in the bustle of all this MDR and all that. These people, out of this 23,000 children, over 50% of them were smear positive. This is remarkable considering pediatric age group and this usually a quoted dictum that we don't get smear positivity, that is why we do gene expert and this and that and all. I think that is a very, very important finding which has got glossed over from this, because it means that even though the WHO has said stop doing smears and cultures and all that, there is still a place for doing smears. In fact, the only advantage of gene expert had been that it picks up more patients than the smear, and it of course gives you rifampicin resistance data very quickly. But smear still seems to have a role, and so therefore it's something which should be picked up. Over 50% had that in this particular cohort.
Yeah. But were there because it was a study which was age-wise a little heterogeneous. The number of children were much lesser. Adolescents and adults were quite, so maybe that may be one of the reasons why we were getting smear positive.
Yes,
Yeah,
that was one of the reasons.
because the thing is, in every kind of TB cohort in children, the bulk of the patients will not be in this under 5. they are going to be, as the children are older, more. And of course, respiratory specimens will be more positive by any microbiological method in that age group. So these proportions are expected, nothing unusual about that.
Yeah.
Even the reported in children below 10 years, the positivity rate was, I think it was more than the 70%, which is really very good, because 70% children being proved microbiologically positive PTV, I think it's a very good number. So I think this, again, as Dr. Matthew is telling, this is a very important observation, that most children in the study, they were proved positive microbiological TB, which is again probably this is a thing that we should make all efforts to diagnose microbiologically rather than starting empirically, because large number of children in the studies, they were positive by microbiological methods. So I think this is very important.
Sir, again, one hitch here is, I mean, they are saying that so many of them are smear positive. They are not talking about the extent of disease. So that also is a factor. Even if a child is 6-year-old and if he has a bilateral cavitary disease, the chances of getting a smear and any microbiological test becomes much higher as compared to just a lymph node disease or just a pleural effusion. So that again is not defined when they are saying that so many are smear positive. What was the extent of pulmonary disease? That is not clear.
Absolutely.
think,
Dr.
I would like to add one important point regarding this their finding: the use of Group A drug. Okay, use of Group A drug. If you are using two or more than Group A drug, then outcome is better. So our NTP program is also recommending now using Group A drug, and we are means now bedaquiline is available in our country also for more than 5 years. In few of the country it is available. It is also permitted to use in less than 5-year-old children. So this is very important. And regarding this smear positive, Joseph sir has rightly pointed out, they have analyzed that those children who are smear positive were having worst prognosis, means treatment outcome was and not better. The reason that Dr. Sushant has told that bilateral cavitary disease or bacilli load is very high, then yeah, then treatment outcome will be poor. So these 2 points they are means highlighted in their study. And one more important, even in less than 5 years, we analyze, we have seen the data in the table. Thus means microbiological confirm rate is very good, around 70% or so. In more than this 15 year, it was around 90, more than 90%. But even in less than 5 years, though data are less, around 8 to 10%. But even in this group also, the means microbiological confirm rate was quite significant in there, means included study. So
But
these
again,
are
as Dr. Jonathan Lengi, they have not told about the disease severity. They have not classified below 5 years, which were extrapulmonary, which were pulmonary. What was the status? They have not classified. Like if they were severe pulmonary tuberculosis below 5 years, the chances of finding microbiologically positive TB are much more higher as compared to primary complex.
And one more thing, sir, they have said microbiological positivity. They have not mentioned whether it is a gastric aspirate, induced sputum, or whether it is an invasive sample like a BAL. So again, that makes a difference. So it is generally seen that the younger the child, if the sample collection, especially in places where the facilities are available, if we don't get a positive gastric aspirate, the patient is subjected to a bronchoscopy and then we get a positive result. So even that could be one of the factors. I don't know about South Africa, but India, I mean, at least in big cities, this facility is available and the patients are referred to get a BAL done, which changes again the microbiological positivity.
Dr. Satya, what was the percentage of clinically diagnosed PB versus microbiologically positive PB in the entire cohort? Was there any division? Percentage of microbiologically positive TB versus clinically diagnosed TB?
Yes, sir. 90% were microbiologically positive and 10% clinically diagnosed, sir. And predominantly they were having pulmonary tuberculosis as compared to disseminated or as compared to extrapulmonary or both in all the age groups.
Okay. Thank you.
Dr. Parveen, you want to say something? Dr. Parveen, AIIMS Jodhpur.
No, sir. Good evening, all of you. No, sir. Already, all has been most of the thing has been discussed. Thank you very much.
Okay, okay. Thank you, thank you.
So over to you, Dr. Ajay Kumar. I think we have discussed this paper at length.
Ma'am, it is already, I think, expert discuss. I think there is some shortfalls in the critical appraisal part of this paper. Sir, Dr. Jagdish sir has taken this paper to I also go through the paper. It is very vague type of things. I have also read all these things. But the thing is, sir, want to say that we can use what the paper say. We can use betacholine and something like that in the earlier age also. Although Dr. Joseph sir said that in this discussion, we are not going to take some message regarding the treatment or something like that. We are mainly discuss on the research protocol point of view, what is best about it. And I think in this session, we already discussed what is Amstar and CASP is why not useful in this case. So this is useful for the resident as well as ourselves also. So I think there is good discussion in this case. Uh, uh, in my view, sir, Dr. Jagdish sir, you select this paper for the session, for this session. So basically, what you want to give the message by this paper?
Basically, in Journal Club, our aim is to means how this fellows and residents should present a Journal Club and how we should critically analyze. Our aim is not to take means
Message.
some positive finding or something like this.
Yes.
So basic aim is how a means resident or pediatric pulmonology fellow should present a paper and what he should know about the paper. So this was our aim. And one more point is most of the systematic review previously was systematic review means we take the study and we pool the data. Nowadays, people are using individual patient data, individual participants data meta-analysis. So in which they take the raw data from all the study and then they uh, find out the result. So somehow means Joseph sir will be right person to highlight this, but somehow people feel that this is the right way that you take the crude data, the chances of error will be less in IPD. So most of the systematic review and meta-analysis nowadays are coming with IPD. So that's why we want to highlight that systematic review and meta-analysis in the hierarchy of evidence, systematic review and meta-analysis are considered one of the top on the hierarchy of evidence. So this we want to means discuss with audience. Joseph sir, regarding individual participants data meta-analysis,
Yeah,
means you
the
have
logic there is,
yeah.
Yes, sir. I am also confused in this one. Yes, sir. Joseph, sir.
so the logic is usually the published studies will provide pooled data, which is the mean and standard deviation or some other parameter for the bunch of their patients. Whereas what is not known in those bunch of this patient is what is happening to individual patients. So when there are wide standard deviations, big ranges, that means there are people on both sides of the extremes. No? So in individual patient data meta-analysis, what is done is the data of each participant is collected by getting hold of the raw data, which means the Excel sheets of the people who have published those studies, rather than using their published collected estimate. And then each patient's data is put up into a meta-analysis program. And then you get for each patient the data. And then the pooled estimate is much more robust, because then you can see what is happening in terms of people who are meeting the criteria, people who are outliers, this and that. And so it is regarded as a much more refined and sophisticated method. It is just like even if you were reading any kind of a journal article of one study and they had 100 patients in it and they say, okay, the mean and standard deviation is this. You don't understand much. But if you had the raw data, then you can make your own calculations, subgroup analysis, and many more things. And that is what is done in a pooled meta-analysis of individual patient data.
Thank you so much, Dr. Joseph. It was really very nice. Your analysis really enlightens us. Thank you so much. If there are no more comments, I hand over to Dr. Rawat for the last words and before we conclude the session.
Okay, thank you very much. So, thank you, Joseph sir, for excellent comments and analysis. Thanks, Dr. Satya, for a good session. Dr. Jagdish, Dr. Sushant sir, and Dr. Indu madam and Ajay for your participation. We'll again meet next month, last Wednesday for another session. My only request is that please use a standard method for critical appraisal as what Dr. Matthew said, because we should use a standard methodology of analyzing or appraising the article. So my request to all the coordinators is that whenever the paper is presented, try to make it in a standard method and use the standard checklist the way you appraise it, so that we have it uniformity. Thank you very much. Good night all. Bye bye.
Good night,
Thank
sir.
you.
Good night, all of you, sir.
Thank you. Bye.
Thank you.
Bye.